For this session, I request Professor Raghunandan sir and Dr. Amit Gupta to kindly chair the session.
Good morning all. First of all, I thank the organizers for giving me this opportunity today. Without wasting time, we will go to the three important topics for the second sessions. First, Dr. A. Panneerselvam sir will be giving a talk on upper limb complications of diabetes. Over to you, sir. Sir is a well-known figure, so I don't want to introduce. He's a leading diabetologist in the city of Chennai. So, normally when we talk about limb complications, we focus more on lower limb. So, we'll be eager to listen to you the upper limb complications of diabetes, sir.
So, good morning to every one of you. At the outset, our profuse thanks to Professor Sheshaya and Dr. Sundaram and Dr. Madhavan. They are all senior people. They are all teachers for us. Without Dr. Sheshaya, department also not there, and we are also not here. So we are happy, sir, that you are present. And Dr. Sundaram, who taught us diabetology during our PG days, 89. Of course, all of us are aware about diabetic food, including IDF in 2005, Save the Food campaign. So everybody talks high about food only, but rarely touched upon. Even I don't think we have talked about upper limb complications. So upper limb complications of diabetes also equally important. We do come across a lot of problems in the upper limb also. So upper limb complications in diabetes affecting joints, tendons, muscles, connective tissues, nerves and skin and soft tissues are under-recognized but prevalent conditions in type 1 as well as type 2 diabetes. Advances in diabetes care have extended life expectancy, leading to an aging population with diabetes with increased susceptibility to long-term complications beyond traditional vascular issues. Upper limb complications are likely to co-occur with one another, with the data suggesting 33% of people with type 1 diabetes experience 2 or more conditions, 13% experience 3 or more conditions. After 50 years of type 1 diabetes, 94% of the people with type 1 diabetes have one or more upper limb complication, compared with 4% in the without diabetes. So upper limb complications including frozen shoulder, deferens contracture, trigger finger, limited joint mobility, carpal tunnel syndrome, ulnar nerve entrapment, osteoarthritis of first carpometacarpal joint, motor neuropathy of the hand, and infections occur 2 to 3 times more frequently in diabetes, with higher rates in individuals aged 50 years and those with long duration of diabetes. The prevalence of upper limb complications, frozen shoulder in type 1 diabetes and type 2 diabetes in non-diabetic. When compared to non-diabetic, so in type 1 diabetes about 59%. Similarly, deferens contracture when compared to non-diabetics in type 1 and type 2 to the higher side. Trigger finger also similarly, carpal tunnel syndrome and ulnar nerve entrapment were osteoarthritis of carpometacarpal joint and limited joint mobility. This is the latest reference from the diabetes care. Frozen shoulder also known as adhesive capsulitis, is a unique condition in that it solely affects collagen in the shoulder capsule. So it solely affects collagen in the shoulder capsule and not in the bones, cartilage, tendons or muscles surrounding the capsule. Although there is no formal agreed upon definition of the condition, frozen shoulder is often defined by a reduction in the range of motion of more than 30 degrees in at least 2 directions with the normal radiograph. The risk of contralateral shoulder being affected later is 15 to 20%. Sometimes bilateral frozen shoulder is difficult for especially all of us, especially lady patients. They are not in the position to comb their hair, they are not in the position to wear their dress, etc. Bilaterally affected, the problem is much more. Stage 1, strong pain without physical limitation in motion. Stage 2, increasing limitation in motion followed by a gradual decrease in pain. Stage 3, limited pain and gradual resolution of stiffness. In diabetes, elevated level of advanced glycation in product and reactive oxygen species have been shown in the shoulder capsule. In addition, significantly increased NADPH oxidase expression and higher collagen 3:1 ratio have been demonstrated in individuals with diabetes in comparison with without diabetes. The main goal of treatment is to shorten the period with the pain and stiffness. Standard treatment include corticosteroid injection, manipulation under anesthesia, and arthroscopic capsulotomy. A wide range of additional treatment options exist, but several of these have proved not to be efficacious, including tumor necrosis factor alpha blockade, acupuncture, and collagenase placed in the frozen cerebral capsule with guidance from the ultrasound. In addition, physiotherapy can be used to reduce pain and secondary muscular symptoms, including stiffness and decreased mobility. Primarily, of course, better glucose control, maintaining glucose control, pulling down the A1C also helps to relieve the shoulder pain. Deferens contracture is a progressive fibrotic condition of the palmar fascia of the hand, characterized by the thickened and shortening of the longitudinal fiber, ultimately leading to flexion contraction of fingers, typically among the ring and little finger. Nodules and cords develop under the skin of the palm, which cause the affected finger to gradually bend towards the palm, making it difficult or impossible to fully extend. Pathology: disordered fibroblast with the deposition of type 3 collagen. Management: local injection of collagenase, intralesional corticosteroid, and splinting. Surgical procedure: fasciotomy, division of affected palmar fascia, or fasciectomy, excision of affected palmar fascia, percutaneous needle fasciotomy also. See, these are all the pictures, especially little finger and ring finger, the thickened cord. This is my own patient for long duration, more than 40 years of diabetes duration. This is another patient. Trigger finger, also known as stenosing tenosynovitis, is a condition characterized by inflammation and subsequent narrowing of the tendon sheath and pathology in the tendon of the finger or thumb, leading to impaired movement. The affected finger may catch or lock in a flexion position before suddenly snapping during extension from the full flexion, often with a painful triggering sensation. The condition occurs when there is a discrepancy in the size of the flexor tendon and the tendon sheath. See, flexor tendon and tendon sheath should move freely. If tendon sheath is glycogen AG is there, the friction may be difficult. The management: good and persistent good control of diabetes is important. Physiotherapy, corticosteroid injection in tendon sheath, splinting and hand therapy. If conservative therapy fails, releasing the use of percutaneous needle approach or open surgery. So this is a trigger finger, ring finger as well as middle finger. And chereoarthropathy or limited joint mobility, otherwise called stiff hand syndrome, is a diabetes specific complication. Flexion contraction of proximal and interphalangeal joint and metacarpophalangeal joints. The skin on the dorsum of the hand typically appears tight and waxy. Pain is usually absent or mild. Swelling, warmth, and tenderness also typically absent. The prayer sign or tabletop sign will identify LJM of the hand. There are 3 stages of tabletop sign. Stage 3, entire palm surface has contact with the table. Otherwise, they don't have prayer sign or stiffness of the fingers. Stage 1, usually 5th finger may not have contact with the table in this stage. Stage 2, 5th and 4th finger may not have the contact with the table. Stage 3 is involvement of all fingers, that is, all may not have contact with the table. Sometimes there may be a restriction at major joints like wrist as well as elbow also. Prevalence in type 1 diabetes 0.9 to 66%, in type 2 diabetes 25 to 75%. Of course, these references are 81 and 83 references. There is some evidences that prevalence rate have declined in type 1 diabetes in the last 20 years due to improvement in glycemic control. So, due to improvement in glycemic control, we rarely see this complication. Of course, I have seen this complication during my earlier practice. During 90s, she is type 1 diabetic, she had a prayer sign. Subsequently, I am yet to see prayer sign in my type 1 diabetic patients. This is type 2 diabetic, again prayer sign with intraosseous muscle wasting. Yet to see again after this patient. These are all the photos taken during 90s. Limited joint mobility is strongly associated with retinopathy and nephropathy in type 1 diabetes and CAD and PVD in type 2 diabetes. It is also associated with other fibroproliferative disorders also. Of course, in diabetes, one complication is there, other complication also there clinically or subclinically. Advanced imaging techniques have demonstrated thickening of skin, tendon and tendon sheath. Histological examination of the skin shows altered mucopolysaccharide elastin and collagen distribution and reduced vascular lumen. Non-enzymatic glycation and accumulation of collagen have been implicated in pathogenesis. Skin biopsy shows pronounced hyaluronan expression in the epidermis and diminished expression in the dermis and basement membrane when compared to non-diabetic as well as a diabetic without LJM. Disordered palmar microvascular flow also is the cause. Management, maintaining the good glycemic control, persistently, physiotherapy, corticosteroid injections at flexor tendon sheaths. So, carpal tunnel syndrome. Carpal tunnel syndrome is an entrapment condition caused by compression of median nerve as it passes through the carpal tunnel at wrist level. The condition results from the increased pressure and in the tunnel, within the tunnel, often due to thickening of the surrounding tendons or sutures. CTS is characterized by transient or constant symptoms of impaired dexterity and sensation, numbness, tingling and pain in the thumb, index and middle finger. See, thumb, index and middle finger and half of the ring finger, as well as weakness or even atrophy in the hands, thinner muscles, etc. Ulnar nerve entrapment. Ulnar nerve entrapment is a condition in which ulnar nerve becomes compressed or irritated along its anatomical location, most commonly at the elbow and less frequently at the wrist level. The nerve entrapment leads to sensory and motor dysfunction with impaired dexterity, including numbness, tingling and weakness in the ring and little finger. See here, ring and little finger, whereas in the median nerve, thumb, index finger and middle finger, as well as in the intrinsic muscles of the hand, and may even lead to pain. Osteoarthritis of first carpometacarpal joint. Clinically, osteoarthritis of carpometacarpal joint 1A presents with a tenderness and swelling around the base of the thumb, particularly in the palm, reduced range of movement and joint deformities in advanced stages. Prevalence of osteoarthritis of carpometacarpal joint is nearly twice as common in people with type 1 diabetes, 3 times high in the type 2 diabetes compared with the non-diabetic. Standard treatment of your osteoarthritis include self-management program, use of orthosis, analgesics and corticosteroid injections. So otherwise, everything to put in a nutshell: frozen shoulder, dipterans contracture, trigger finger, carpal tunnel syndrome, ulnar nerve entrapment, the various treatments they have highlighted in this picture. So intrinsic muscle wasting of hand. So hypothenar muscle, thenar muscles and lumbricals, intrinsic muscles, and this patient has hypothenar as well as thenar muscles, uncontrolled diabetes for more than 5 years and 10 years. Not only your sole muscles are getting wasted and hand muscles are also getting wasted. See intraosseous wasting, dorsal aspect, and again first intraosseous muscle wasting. So these are all the various pictures, not only both hand, our feet also. So this is wrist drop, radial nerve palsy, another patient wrist drop, infections and amputations. So this is a chronic fungal infection with a superadded bacterial infection, and while they do the blood test, unsterile needle causes infection of the fingertip, and again unsterile needle causes infection of the fingertip, and they have burned camphor in the palm, in the temple, in presence of uncontrolled diabetes, inviting the infection. This is another infection getting healed totally. So amputation of the thumb, amputation of index finger, amputation of middle finger, amputation of little finger. So amputation of index as well as toe finger, amputation like your below knee amputation, below elbow amputation also happening in type 1 diabetics, uncontrolled, and gross foot infection of the hand. So we had a hell of a time, about it took 3 or 4 months for him to get healed with a skin graft to save the upper limb. Of course, he lost his thumb. So this is about upper limb complications of diabetes. So we have to concentrate on the upper limb complications. Persistent good control definitely avoids all the complications, including retinopathy, nephropathy, neuropathy. In addition, food complication as well as hand complication, upper limb complications. The purpose is, as Dr. Sheshaya is here, we have to prevent diabetes per se, primordial prevention, preventing diabetes per se in the pre-diabetic stage, and maintaining the good control. This is very much possible, by which we can avoid all complications in future. Thank you for giving me this opportunity for giving this topic. Thank you.
So it's now time that we talk about type 5 diabetes, new type of diabetes, and to present this topic, I would like to invite Dr. Felix from CMC Vellore. And as you all know that type 5 diabetes, though we talk about type 5 diabetes for last several years, but recently the IDF has endorsed this term, and during the IDF Congress in Thailand this year, this term was endorsed by the IDF, and now there is a dedicated task force which is working on the type 5 diabetes, and many Indians are working on that, and Professor Dr. Nihal Thomas is leading that task force. So Dr. Felix, over to you for your talk.
Good morning everyone, and thanks to the chairperson and for introducing me, and in the outset also thank the organizers for inviting me to talk about on type 5 diabetes. If you start looking at type 5 diabetes as a new diabetes, it's actually not a new diabetes. It's actually a diabetes which is still prevalent for the last 60, 70 years, which we are just trying to see why we have actually missed it out over the last few decades. So my scheme of the talk would be on these aspects, and let's see what we understood about the concept of type 5 diabetes. So when we talk about lean, we always interchange with malnutrition or undernutrition. There are several studies which are being conducted across the globe, and recently if you look at a Lancet publication which actually talks about their concept of lean, and they divide the people who are visiting the UK Biobank or maybe on their database, and found that the South Asian population, what they call lean is when they are less than 19.2 kilogram meter square. But these are the studies which are done in United Kingdom, not probably for us. And till date we have only BMI, which is a marker for the nutrition. Though there are several markers other than BMI is there in the marketplace, we still have a very easy marker on the bedside, which is actually BMI. So still we need to rely on the BMI as our marker for nutrition till we find out a new marker with the advent of omics studies and etc. So for our understanding, I would say for the clinicians, the BMI is still 18.5 kilogram per meter square or less. We should call somebody lean till we find a new marker such as body roundness index. Several markers comes into the literature. Even few days back you can see several new markers. So what is lean is 18.5 kilogram per meter square and less than that. And what is exactly young is some books says about 25 years, some studies talks about 30 years, even in some of the publication from India talks about 35 years. It's not about the age, or it's actually probably what we need to look at patient in a toto. So when you come into the lean, we say it's 18.5, and probably young, let's say keep it as 30 years. And what will be the differential diagnosis? Because if I ask someone what exactly the criteria for type 2 diabetes, there is no clear criteria. It's our clinical experience, and we think in our mind that there is no type 1 like picture, there is no pancreatic features, there is no other features to suggest other syndromic, and we name it as type 2. So as such, it is actually a diagnosis of exclusion, because there is no clear criteria. Like if you ask LADA, or slowly evolving autoimmune diabetes, there is some kind of criteria around. So similarly, if you want to really look at any patient who is less than 18.5 per kilogram per meter square and having diabetes, we should have a clear history, pedigree charting, physical examination, subtle investigations like C-peptides, if you are able to do a mixed meat tolerant test, and anti-GAD antibody. These are the must. And of late, ultrasound plays a major role because it gives enough evidence about the pancreas morphology. If you do have an enough support system, you can further go into that, looking at the body composition, next generation sequencing to look at the monogenic diabetes and revalidation, and if you have to go further on, you could do an MLPA also. So, but for a clinician, what could be the differential diagnosis if someone comes with a lean BMI and diabetes? This is probably the package of diagnosis we should think in our mind. I'm not going to the detail of every buddy who comes with lean BMI and having this other diagnosis. I'll be focusing only on type 5 diabetes, but remember that these all has to be considered when someone comes with lean. So what exactly type 5 diabetes? So I'll start with a case. So this gentleman is extremely lean, from a rural background, has lost of weight, and when we found that his birth weight was 2.2 kg, and he was adequately breastfed for 2 years, and he was from a middle class family. And his BMI was 15.9 kilogram per meter square. He was pale, and otherwise he did not have any features to suggest malnutrition or undernutrition. His HbA1c showed quite high in terms of his glycemic status, and you could see he had hyperlipidemia. There were no family history of diabetes, and his protein levels were normal. And further investigation showed that he has low C-peptide levels, but he never had ketosis. His fat did not show any infiltration of fat, and his ultrasound and the CT abdomen also did not show any pancreatic morphology. So where do we put them as? He did not have ketosis, and so, and we further move ahead with his body composition, which showed body composition on the low normal. And you can see it's less than 25% of his body is having fat, but he did not fall in the category of lipodystrophy. And we further went ahead and see that did he have any genetic mediated diabetes. That also been ruled out with our 62 gene panel, which we have in-house in CMC Vellore. And who are these people? Lean, young onset, non-autoimmune, fasting insulipidemia, pancreas was normal, low body fat, not into the account of lipodystrophy-like feature, never had ketosis, no genetic disorder. To the extent of genetics we know in this current context, does he qualify for type 5 diabetes? Because name does not matter, because if we don't look at these patients in a different angle, we probably put him on label him at type 1 diabetes and put him on insulin, and he'll be on long-term insulin. This patient, we are following it up, and he is only on glimepiride 3 mg once daily and sitagliptin. You may be asking why sitagliptin. We also done a study and found that these patients have low incretin levels because of several reasons, and he was put on sitagliptin, and he is on a good glycemic control over the last 10 years. So if you look back, this is not a new entity. This was there in the textbook for many years, but it was vanished out because of the lack of clinical evidence and the literature evidence across the globe. But if you look at these studies which subsequently came into the literature, there are several case reports and isolated studies from the African context, Bangladesh and even Pakistan also has shown several literature on these kind of patients with lean BMI, with non-ketosis, who has well controlled with OAD and never been into further ketosis despite of being on OADs for longer duration. So these are the several studies over the last 5 to 10 years. I'm not talking about the studies before 1999. These are the studies which came over the last 5 to 10 years, which talks about the non-autoimmune disease in terms of diabetes. Who are we looking at? So that needs further study. And even Vellore also, with my mentor and my colleague, Dr. Nihal Thomas, we did a study and found that these are the patients who are insulinopenic but never had ketosis, and around 60% were requiring only OADs. That means oral anti-diabetic agents. They never had ketosis. Over the last 10 years, we are following up, and they are still on OADs. So that leads on to the context of, as Dr. Amit already told, that Professor Peter Schwartz introduced the concept of type 5 diabetes, and to have a working group to understand and see what exactly we are dealing with and how to go about in the next 2 years' time. And recently this was a publication which was done by Professor Yajnik. I want to have a close look at these column where you can see that the patients with BMI of 18.5 and kilogram per meter square, these are people from Assam tea garden who are working all through the day for their life, and actually if you look at very carefully, they have low body fat, they have less insulin, and they are actually having a lower waist circumference, and who we are dealing with this. Is this accounts for type 2 or type 5 diabetes? Because these are well preserved people who never had ketosis in the past. And further, if you look at carefully, they have higher HbA1c, lower C-peptide, and insulin sensitivity is preserved, and they have a slightly higher cholesterol levels as well. So these are patients who are having a lean BMI with diabetes, but not accounting for type 2 like picture where we see insulin resistance and hypertriglyceridemia, but not to the account of type 1 diabetes. So recently another study came into the literature just a couple of months back. This is called SAMPA study. These are the studies who they followed patients with malnutrition and try to find if they have a malnutrition during their young onset, that means young adulthood, and subsequently when they are actually followed up, they found that they had greater dysglycemia at 120 minutes. What does that mean? That means if the patient is having malnutrition at their younger age, or maybe even intrauterine, when they are not given adequate nutrition or undernutrition postnatally, they have dysglycemia. So that is what it implies. It is opposite of Barker's hypothesis where there is undernutrition, overnutrition, type 2 diabetes. This is just an opposite of that. So this picture probably will help us in understanding, which was designed by Professor Yajnik, and he gave to us for further understanding. Somebody has an undernutrition during pregnancy, during the intrauterine, and probably in the postnatal, and if they have overnutrition, they have type 2. This is Barker's hypothesis. And if they have undernutrition during the life course and subsequently have a double hit, that means there is another malnutrition during the adulthood, potentially they could be type 5 diabetes, which we are seeing in current context. And recently also Mohan et al. Has actually shown the similar picture. If you look at carefully, the study talks about why we need a separate entity. We don't need a separate entity because as a clinician in the bedside, probably we need much more clinical understanding. So if they look at carefully, they also talks the same tune, higher glycemia, lower C-peptide, and cholesterol levels are slightly lower. If you read through this study, you can see that at least 40% of these lean BMI diabetes were requiring only OADs. Though they mention they are treated with insulin, but if you look at the study in a much more granularity, around 40% were on either diet modification or on OADs. So that means this also talks about could be a type 5 like picture in their entity, but this is a large scale data over around 4 lakh population from a center from a not from the rural India. So there is a bit of a difference here. So what exactly type 2? Insulin resistance and beta cell dysfunctions, but we are not looking at beta cell dysfunction completely or insulin resistant. Here we are looking at normal or low insulin resistant plus beta cell dysfunction. So this could be a different entity because as a clinicians, we need not put them on insulin long term and make them continue to be on insulin because up to 40 to 50% might go very well with oral anti-diabetic agents before we labeling them as type 1 diabetes. So these are the few points to ponder. If a lean BMI diabetes you encounter, if they don't have autoimmune nature, a BMI, if you are able to say that less than 18.5 and have a poor insulin secretion, no hepatic output, a simple ultrasound did not show any fatty liver, and if you are able to do a body fat assessment with even bioimpedance or a DEXA and shows that they are not like type 2, we might need to look at this as an entity. So why this all happened is because if you look at the African context, especially in the Western Africa and Northern Africa, there are quite a bit of patients with lean BMI and diabetes, so that should be some further research and awareness should happen. So this is going to be a next publication which will be coming out in the near future, which talks about the concept of lean BMI diabetes potentially having undernutrition and labeled as type 5, and probably in the next week it will be in the literature from Lancet, and this or the potential features of type 5 diabetes, starting with BMI of less than 18.5 kilogram meter square, mild to moderate to severe hyperglycemia, low C-peptide level, no ketosis, no insulin resistant, never had GAD antibody positive, and the other accessory features like low birth weight, undernutrition in infancy, difficult to get a history, and if you encounter with a normal pancreas and normal or low body fat, one should look at this and probably look for adding OADs on these patients rather than label them as type 1. And more important is rural origin, low socioeconomic status is a very important thing. So in concluding, type 5 diabetes has subtle insulin deficiency, not like type 1, has insulin deficiency, not like type 1, preserved insulin sensitivity, low body fat percentage, no hepatic glucose output. OAD should be looked at as an option, and that could be an antenatal or postnatal undernutrition followed by a subsequent undernutrition causing type 5 diabetes. But one should not forget the differential diagnosis which I mentioned in the past, because still it could be a type 1 diabetes in the honeymoon phase, could be a monogenic diabetes, could be a Wolfram-like syndrome, could be a LADA, or could be anything, even HIV related lipodystrophy or a lipodystrophic diabetes. Rule out all the causes, and if you are able to rule out, look for type 5 diabetes and treat with OADs. And we need a lot of future algorithms to really focus on this and the therapeutic intervention as well. This is to put on a nutshell for all type 5 diabetes. If you're able to rule out all, probably you need to look at this as a diagnosis and treat. And these are the various support, and thank you so much for patient listening, and this is all our back-end team and the front-end team. Thank you.
Thank you, sir, for your excellent and bringing out the nuances of the emerging type of diabetes 5 to the audience. We'll have the question sessions in the end. We'll go to the last speaker of the second session, Dr. Mahadevan. He is going to tell us on the international guidelines of approach to heart failure in diabetes with Indian approach.
At the outside, I thank the organizing team for giving the opportunity to talk in front of this august audience. And my topic of the day is heart failure in diabetes, how the Indians are going to approach based upon the international guidelines will be the talk of the day. So the introduction is heart failure is end stage of any form of heart disease, maybe a cardiomyopathy, ischemic cardiomyopathy, dilated cardiomyopathy, or HCMs, any form of heart disease. If it's not properly treated, the end stage is going for a heart failure. And the important, one of the most cause morbidity and mortality in the elderly population is heart failures. And this as like a diabetes is a progressive disease, one admission begets another admissions, worsening the event of mortality scores by more than 10%. The main cause of death in heart failure is sudden cardiac death or any organ dysfunction, maybe kidney or a liver, due to its hyperperfusions. So as per the definition of Boskert, which was published in European Journal, what is heart failure? It is a clinical syndrome with the symptoms and signs of either a structural or a functional or both cardiac abnormalities, collaborated by elevated natriuretic peptide levels and objective evidence for any form of congestion, maybe a systemic or a pulmonary congestion. If it suits it, the patients can be called as having a heart failures. So these are the stages of heart failure. At risk, the patients have a diabetes, at risk of heart failure. Patients have hypertension is at risk of heart failure. The presence of risk factor alone is called as a stage 1 heart failure. And stage 2 is a pre-heart failure. There is structural changes without any symptoms. And the heart failure stage 3 is symptoms. So at risk is stage 1, structural changes is stage 2, and the symptoms is of heart failure carries a stage 3, and advance is refractory to the guideline directed therapy where requires instrumental assistance to improve the EF. So how you are going to classify the heart failure based upon the EF, which is an easy marker for us to do assess by the bedside echocardiograms. So one is reduced ejection fractions. Now the criteria has been changed. Initially it was 50. The EF is less than 40, we call as heart reduced ejection fraction with signs and symptoms of failures. And preserved ejection fraction and the EF crosses more than 50. When the EF is more than 50, it may fall in the normal category. Then how we calling it as patient having heart failure? There should be signs and symptoms of any form of congestion. On top of that, there should be evidence for reduced left ventricular filling. That is attested by diastolic dysfunction in the echocardiograms and also elevated natriuretic peptide. Another form is mildly reduced ejection fraction when it falls in between, like a pre-diabetes. When the EF falls less than 42, 49, we call it mildly reduced ejection fractions. One other term, suppose I put a patient on guideline directed therapy, the patient comes to my clinic with EF of less than 35, I put the patient on guideline directed medical therapies, on follow-up the EF is improving. That is called improved ejection fractions. The baseline EF falls in the reduced ejection fraction categories, and when I put the patient on medication, when there is improvement of EF from the baseline to 10%, I call as improved EF, that is heart failure with improved EF. So this is the spectrums. So reduced ejection fractions, mildly reduced ejection fractions, and normal EF, and all the things. So mild and normal EF falls under the category of preserved ejection fractions. And one thing we have to understand, all the things are interchangeable. So one patient comes to the clinic with reduced ejection fractions. If you properly treat, the patients can go for a recovery to the mildly reduced or even to the normal ejection fractions. So what are the factors that determine decline in the EF? Is the presence of diabetes, presence of ischemia, presence of other comorbidities, low adherence to the therapy, all the things tilt the balance towards a negative angle, that is preserved to reduce ejection fractions. On the other hand, people with young female patients with less comorbidities, well optimized diabetic therapies or heart failure therapies, there is maybe progression of the heart failure into the positive stand. So this is the way diabetes is going to produce heart failure. It is not only the ischemic heart disease alone. The diabetes, because of the metabolic abnormality, hyperglycemia, hyperinsulinemia, more things goes for advanced glycation products that occurs in the myocardiums. On top of that, the metabolic alterations, the lipotoxicity and increased inflammatory milieu sets the heart to function in an abnormal background. So that produces structural changes that produces abnormal filling of the left ventricle that translate into the normal heart to abnormal heart in terms of its functions. What are the epidemiology? How we differ from the western part of the globes? We have a heart failure a decade earlier. Average age of heart failure of an Indian subset is 60%. When you go by the registries by the western populations, in US it's about 74 years, European heart failure registry is 70 years, and Japanese registry is 73 years. So we get a heart failure in a younger age compared to the western group of peoples, and these are the people of the breadwinner of the families. So these are the people who are taking care of their families to the great extent, where heart failure reduces the longevity of the life, quality of the life has been impaired. So younger age also have a negative impact on the social. Our country will not progress in the socio-economic status. We have more heart failure than that of its individual aspects alone. So we have a more male counterpart compared to the female part in India. And predominant form of heart failure, what we diagnose is reduced ejection fractions. If you go by Western literature, they have more preserved ejection fraction categories. But in India, we have low much of burden from reduced ejection fraction. And nearly this contributes nearly 60 to 65% of the heart failures. And one of the commonest cause of heart failure, what we see is ischemic cardiomyopathy, because the dilated cardiomyopathy, other forms are not properly screened and properly evaluated in India. So how we differ from other aspects is mortality is phenomenally very high. When you go for Europe, the mortality is about 5.5%. We have our mortality is crossing more than 8.4% of heart failure. And major cause of death in India is sudden cardiac death. Many of these can be prevented. If you put the patient on CRT, if the patient is affordable for ICD, you can prevent the sudden cardiac death. Because of the financial constraints, the underutilization of device, we see more sudden cardiac death in India compared to the Western group of failures. And nearly device use is very, very minimal. We use less than 2% of device in advanced heart failures, whereas it crosses more than 30% in Europe, mainly because of the poverty, mainly because the patient has to pay from his pocket. These may be limitations for us to use device in advanced heart failure. So how we are going to diagnose heart failure? Pay attention for the clinical histories, because good clinical history by a physician can give insight not only to etiology, can also use the perspirant factors. Patients may not be taking therapy, patients may have an anemia, that can be a trigger for his, patients may have a suffer some infection, that may be a trigger for his heart failure, and also severity of the heart failure, the quality of life can be compromised. And change in body weight, sudden increase in body weight shows there is a subtle signs of congestions. The patients, many of the patients may have features of pulmonary edema, where there is a need to escalate the diuretic therapies, where you can change the therapy in terms of decongestion, so the patients can be avoided to get admitted in the ER. So what are the main causes of heart failure? Irregular medications, ischemia, infections, irregular rhythm, that is what we call as arrhythmias, and iron deficiency anemia, intoxications. These are the common causes of repeated admission or precipitations of heart failure in our subsets. And biomarkers, don't get confused, go for BNP if it is affordable, and only one problem is if you do BNP, if it is there, it shows there is a disease. If there is no, if it is negative, you can rule out or rule in whether the patient is having heart failure or not. But routinely we do NT-proBNP, we won't order BNP level, because NT-proBNP has more sensitivity. So it can easily, the NT-proBNP is normal, the patient is not having heart failure. And when you put the patient on ARNI, is what the common use in heart disease, there may be subtle elevation of BNP, don't get worried. So focus on the clinical symptoms of the patients. That is more valid tool than going estimating the NT-proBNP all the times. This is a summary of things. It is a very crowded slide. So give anthropometric measurements, focus on the weight of the individuals, focus on the other parameters which can pedal edema or JVP elevation, something else, and go for other tests like heart rate, BP. These are the things every physician is mandated to do for any patients. I am not going to do cardiac MRI, I am not asking you to do for a genetic analysis. Please pay attention for the anthropometric measurements, pay attention for the heart rate and blood pressure. That gives a vital clue how the patient is going to react in next. And then you can go for a 6-minute walk test to assess the quality of life of the individuals. The patient's quality is improved on, because after guideline directed therapy, you are going to reduce the mortality and morbidity, but quality of life has to be improved. Whenever you say a patient of heart failure, the first thing is they will ask whether I can take water, whether I can take salt, whether I can do walk. These are the things which commonly I do without any hesitations. These are the basic fundamental of human beings that being impaired when a patient gets heart failure. So please assess under your guidance whether the patient is suitable to go for a good walk. So exercise also improves the longevity in the patient with heart failure. So non-pharmacological measures, many of the methods, when the patient is having heart failure, many of them we say reduce the salt. So you should not take much more. The sodium heart failure trial are clearly showed patient with heart failure who are ambulant, who are not having any congestions, who are not having oil, low salt diet does not reduce events. So don't restrict salts in an ambulant patient with reduced ejection fraction and no heart failure. Many meta-analyses on this angle have clearly showed they may reduce the symptoms, quality of life, but reduction of salt does not translate in terms of reduction of mortality or a hospitalization for heart failure. So other way around, don't ask the patient to take more salts. So when you give some sort of leverage a patient to an extreme, they used to start to consume salts. So many of the times we say reduce to salt, but that does not translate in terms of benefit in terms of mortality reduction. Another is the water reduction. Many of the times we say 700 ml or 750 ml per day is allowed for heart failure. That also has been futile. It has not been clearly showed. So recommendation of patient with congestion, patient with pulmonary congestion, systemic congestion, there is a role for water restrictions. Patient with the CKD heart failure, there is a role for water restrictions. But ambulant patient without any form of evidence for congestions, restriction of fluid has been turned to do anything. So thirst and weight gain are the good tool for the patient to take water. The patient is putting on weight, restrict the fluid intake. They have a good thirst, you can allow the excess consumption of water. So fluid and water restriction for ambulant heart failure patient is not going to do anything. Exercise training, many of the times patient will say, how much amount of work I can do, whether what the activity I can do. So many of the trials, the Cochrane analysis of many of the trials has clearly showed the heart failure patients can do guideline directed exercise. There is a cardiac rehabilitation exercise there. You can do it. You can do it modified Bruce protocol TMT can be done for heart failure patients. So heart rate can be monitored, BP can be monitored. You can prescribe what level of exercise can do the patients. So regular aerobic exercise and inspiratory muscle trainings are recommended even patient with heart failure. These are the patients which comes to your clinic. I am not talking about the patient getting admitted in ICUs. The patient who is coming to clinic for a follow-up, these are the things we have to do for the patients. And please pay attention to the vaccination, because these vaccinations can reduce another event of admissions for heart failures. So non-pharmacological messages, so salt intake as carries subtle evidence in terms of patients having admitted for volume over congestion. You can prescribe exercise to the extent how the patients can do under your supervisions. Nutrition is very, very important, because anemia has to be curtailed, anemia has to be optimized, medications has to be given. So vaccinations and fluid intakes, all we have talked about. Next in line is pharmacotherapy. We know that there is 4 pillars of pharmacotherapy. I am not going to intel what are the drugs we are going to use. So by adding this therapy, you are going to, suppose I am adding this therapy for a heart failure of 55 years old, I am adding 5 years for the individuals. So 55-year-old male coming to my clinic with heart failure, if I optimize, if I am able to start this medication, optimize the therapy, I am going to add at least 6 years of life for him. So this therapy should be started within 6 weeks. Why you wanted to start within this, all the 4 drugs to be in there, there is no contraindication with the 6 weeks. There is a trial called Strong Heart Failure Trial. They have clearly showed the patients are repeatedly admitted within 6 weeks. So one heart failure admissions, the patient next admission will be fall within 4 to 6 weeks. So within that durations, you have to optimize the therapy with the standard, the mortality benefit proven drugs like RNE. If not tolerable, you can go for ACE inhibitors, ARB, and beta blocker and MRA and SGLT inhibitors. So and one of the things is when the patient comes to, even for a BP, when the BP comes to normal, the patient will ask whether they can stop the medication. Same thing goes for heart failure, because the polypill is there, many number of medications there, cost is very huge. So whenever the EF goes to normal side, they will say, can I stop the medications? Even the physicians may have a tendency to down titrate the medications. If you do, the probability of recurrence is very, very high. So when patients comes to my clinic, I am putting all the 4 drugs therapy in the armamentarium of management. If the EF improves to 55, I should not have a tendency to downgrade. Please continue the medications until there is no contraindications. So these are the green signals of the class 1 medicals, which has been, if there is a congestion, use diuretics. So mildly reduced and preserved exacerbation does not have any difference. Only one drug that has been given a 2 years SGLT inhibitors. All other RNE or beta blocker class is a 2B only. So green are class 1 indications, and heart failure and preserved exacerbations mildly reduced, only SGLT inhibitors cost much than this. But what are the blind spots we have? So there are delayed initiations. We are not optimizing therapy. There are more delayed on the physician aspect because we have fever. Many of the heart failure patients comes to the BP of 100. You can't expect 160 BP of the heart failure patient because the pump is under failure. So all the heart failure medications are BP lowering medications. So I will be worried to start RNE, I will be worried to start beta blocker, I will be worried to start MRA, because patients may have a fear. And all the patients have fatigue, low cardiac output symptoms. So if I put the medications and BP falls down, what happens? So this may be fear in my side, so I will be reducing the medications, I will not be updating the medications and medicines. So suboptimal titration because of the renal dysfunction and polypharmacies, and the cost is one of the barrier, and there is a wide difference of practice between the rural and urban treatment inequalities. So challenges, hypotension, so you may expect a fall in GFR, CKD uptitrations and hyperkalemia. These are the 3 things which is a concern for us to update the medications. So please pay attention before starting RNE. If there is a role for removing the diuretics, please do it. The patient having no congestions, patients free of congestions, please remove the diuretic or stop the diuretic, because the diuretic has not proven any mortality benefit. So you can use MRA in place of diuretics, or you can use RNE in place of diuretics when you want to use medication. Unwanted hypertensive medications, please remove the patient, because these are the things that can reproduce. Patients may taking nicardia, patients may taking calcium channel blockers on top of heart failure. Please remove, because that drugs are not been proven any benefit in terms of this. And patients may taking non-steroidal drugs, that has to be reduced or removed from the prescriptions. And worsening, please, until creatinine is 2.5, you can use based upon the EGFR. Don't worry about that. But potassium carries, if the serum creatinine increasing 2.5 or a potassium crossing more than 5 point, that is the place where you have to stop or down titrate the medications. So beta blockers, so don't put the patient when there is a fluid overload. If the patient is taking fluid, patient is having more congestion, don't put the patient on beta blockers. So please, that increases the mortalities. So make the patient euvolemic, patient put the diuretics, make the patient decongestants. If the lungs are clear, if there is no evidence for congestion, please go with beta blocker, but pay attention, go for a low dose beta blocker, cardiosedative beta blocker. That is the reason many of the heart rate doctors will be prescribing bisoprolol 1.25 mg, metoprolol 12.5 mg. These are drugs that will not have any effect in terms of BP reductions. SGLT inhibitors, that is well-known drug, produces glycosidase and natriuresis. Apart from that, it also reduces the preload and afterload for the heart and improves the myocardial metabolisms, makes the heart to function in a proper manner, and also reduces the cardiac fibrosis that has been turned much things. These are the class 1 indications. I am going to talk about the second line, because patients may have a kidney disease where you can't update it RNE, where you have to search for a second line of medications. One of the drug that has been proven good benefit from the Victoria trial is Versigut, that reduces the calcium, that is reduces the mortality by 10%. It's a drug that is going to increases nitric oxide, which is anti-hypertrophic, anti-fibrotic and vasodilatory effects. So this produces vasodilation. You don't worry about the kidney and all. So no need to worry about the kidney. Just pay attention to the BP alone. One thing is contraindication anemia, because that increases anemia events. Evaporatin only when the heart rate is more than 70 if the patient is taking adequate dose of beta blocker. So don't put all the patient on evaporatin. Digoxin, now it is becoming newer drug. ESC has published that digoxin can be used. It is coming back again in the heart failure management, but I use mostly in AF with reduced ejection fractions when the patient is not having appropriate control of heart rate and heart failure. So hydrolysin, this is one of the drugs which use in when there is a contraindications for RNE or mRNA, because patient heart failure may have a cardiorenal syndromes. At that angle, we use this molecule. Iron also plays a very, very important vital role. If the ferritin level is less than 100 or transferrin saturation less than 20, please give ferric carboxymalate, because studies are given there is improve the quality of life and functional capacity of the individuals. So there is a role for iron. Check the serum ferritin level, not only hemoglobin. The ferritin is very, very low. Please pay attention. You can use injectable intravenous ferric carboxymalate, at least 500 mg once OD, and you can check the hemoglobin or serum ferritin after 2 weeks or 4 weeks. You can update it when you want. So statin does not have any role in terms of heart failure, but patient heart failure is mainly because of coronary arteries. Yes, statin has to be used. So DCM with heart failure, no role for statins. Hypertrophic cardiomyopathy with the heart failure, statin does not have any role. So sequencing of ARB therapy is also I am going to talk it now. So many of the times, this is the traditional sequencing. Initially, you put the ACE inhibitors, beta blocker, then mRNA. Now it is not so. We want a rapid sequencing because we have to have the benefit within 4 to 6 weeks. So initially, SGLT does not have any. Sorry, sir. SGLT does not have any contraindication. You put the patient on SGLT inhibitors. There is euvolemic, you can put a beta blocker. Based upon the kidney angles, you can use other medications in lines. So these are the drugs where it is, when the AF is there, what you are going to use. When the CKD is there, what you are going to use. When the heart rate is very low, what are the things you have to use. So sequencing of therapy, if there is a congestion, put diuretic. Our first line is SGLT inhibitors, and there is no hypervolemia, put the patient on beta blocker. On all the drugs should be there before the patient getting discharged. So another tentative is preserved infections where EF is more than 50, and evidence for abnormal LV diastolic filling and increased natriuretic peptidase. So Indian registries, the prevalence is very, very low. These are the risk factors for preserved ejection fractions. And pathophysiology is not the vascular tree, more on the myocyte. There is hypertrophy of myocyte, intracellular fibrosis, and abnormal myocyte relaxation inflammations. These are the screening tests that can be do. What are the patients having? When you want to diagnose heart failure with preserved ejection, there are two trials that have been approved by ESC and ADA. These are the trials we can use, scores, we can put the patient on this. So any signs of heart failure, if you do echo, EF is more than 50, and there is evidence for diastolic infection, check for the filling pressure, E by E dash, or pulmonary hypertension, or LA volume. If everything scores correct, you can label the patient as preserved ejection fractions. And drug, we have diuretic and SGLT inhibitors as proven. CKD, check the eGFR. If it is more than 60, you can start all the drugs at low dose. If the falls between 30 to 60, you can start beta blocker at low dose, and you can start full dose of SGLT inhibitors. If the eGFR is falling 15 to 30, please give low dose beta blocker. If already on SGLT inhibitors, you can continue SGLT inhibitors for these patients. Thank you for the patient listening.
Thank you, sir. I think all the three speakers have done a good job. Now the forum is open for discussion.
All the three speakers, they have presented, given excellent talk. I would just like to highlight one point here. Diabetes Association of India is one of the only association of the India who is also the affiliate member of the IDF. So apart from the RSSDI and the Diabetes India, Diabetes Association of India is affiliate member of the IDF, and this is really a proud thing. So I really appreciate that, and congratulations to all the organizations. And this is the only chapter apart from the Mumbai which I see is the active in the entire India. So congratulations again to all of you. So 3 talks, sir, please, your questions, sir.
Dr. Mahadevan, you were talking about a big list you are given for heart failure treatment, so many drugs. I have a patient who is a fairly controlled diabetes, who comes with dyspnea on exertion. He is found to have EF with normal ejection fraction. He is not on glyphosate. Next, my choice is whether glyphosate or a beta blocker. And the second question is, you were telling about digoxin is coming back. Digoxin is one of the old drugs. Many of us seniors have been using left and right. Under what situation it is coming back? Is it after stopping all the, adding all the other drugs and then digoxin? I just want you to highlight on it.
The first thing is the patient, a diabetic patient coming with breathlessness, first you need a diagnosis. Suppose EF is more than 50, you have to check the presence of LV diastolic relaxation failure. So that you can do by echocardiogram or doing a biomarker like NT-proBNP. If the patient is breathlessness with EF is more than 50 and NT-proBNP is elevated, you can put the patient on, diagnose the patient on preserved ejection fraction. Yes, it becomes a candidate to start on SGLT inhibitors because that does the drug only given a mortality benefit in preserved ejection fractions. If there is no diagnosis of preserved ejection fraction, you can continue DP4 inhibitors. You must know what is the cause for breathlessness. You have to check for anemia, you have to check for the lungs for the cause of breathlessness. Next is digoxin is coming because of latest ESC they have published articles. There is no change of any 4 pillars because we have difficulties to put all the drugs in the basket for a failure because one is renal shutdown, one is electrolyte imbalance, another is patients may have hypotension episodes. So patient with low EF, if arrhythmia is very high, if the patient is congested, the beta blocker or any other ivabradine does not have any mortality benefit. In that angle, you can use digoxin because digoxin is one of the molecule that has been timely tested. Why it has been gone out of the market is therapeutic window is very, very low. So toxicity level is very, very low. The monitoring of digoxin's level is very, very low in our subset of population. So since we have a safer drugs, we moved away from digoxin. Now, because of so much of constraints, because of using the 4 pillars of heart failure, we are searching for the additional drugs. So one of the drugs is digoxin.
So this digoxin is used with with atrial fibrillation or even without atrial
Definitely atrial fibrillation with low EF because I can't use beta blocker, there will be pulmonary congestion. So I have to use either cardron or a digoxin. So out of this, there is time tested quality of life improvement is there, digit heart failure trial. In that subset, it shows mortality benefit.
Thank you, sir. We'll take one more. We are running short of time. Yeah.
Sir, for Dr. Paneerselvam, sir.
It's almost similar, but if you look at the malnutrition modulated diabetes mellitus, it includes protein malnutrition and also it included pancreatic diabetes also. You're right, it is the old diabetes which is coming back probably the same, but with the more advent of investigatory methods, we probably will rule out pancreatic related diabetes and other form of diabetes, and the idea is to not to label them as type 1 or other form of diabetes and treat them with insulin long term, because these patients do perform very well with OADs, and studies have shown recently also up to 40 to 60% of them go very well with oral anti-diabetic agents.
Thank
Sir,
you.
to Dr. Mahadevan, sir. Sir, the latest, in the yesteryears, we were using Previnar 30, followed by PPSV 23. Now the concept has changed. Now we have come to Previnar 20. You give one shot of this injection, PPSV 23 is not necessary. This is the very latest. I'm talking just about a month or 15 days ago. So this is the concept. So PPS I mean, PPSV is going to get away from the armamentarium, and Previnar 13 also is going to get away because we have got Previnar 20. So this is one thing which is I want to update in this forum, sir. And regarding the heart failure preserved ejection fraction, what will be the presentation of the patient, sir?
More of pulmonary congestion, sir. Patients will have, that is the reason the criteria enrolled LA dilatation, that is LV diastolic dysfunction, back pressure in the LA, and the back pressure and pulmonary congestion. So patients may have more of pulmonary congestions.
No, the question is, how will the patient
Exertional
exertional dyspnea? So we have to make sure that he is not a COPD or a
True.
asthmatic. Okay, sir.
Okay, thank you, sir.
Thank you.
Thanks.